well-known figure in India. At this present moment of time, she has visited India and enlightened us with her immense knowledge in bone marrow transplant and CAR T cell. She works in Spain and she does not need much of an introduction to the audiences across India, Southeast Asia, and Middle East. There will be close to 200 to 250 people joining in on this evening at various time points in their time zones. Thank you, Dr. Anna. 6:30 in the morning, and you have taken the time out for next 30 35 minutes. This Innovation in Hematology is a series which has been run around for 2 years, and all the great speakers have enlightened us how and what they are doing in their local practices. So, CAR T cell is familiarized with the people in the various parts of the country. So they are looking towards and understanding the CAR T cell toxicity, and we heard in ASH also the European Society for Hematology has done a remarkable job in the CAR T cell arena. So, keeping this in mind, we'll not take much of your time. We will invite Dr. Anna to deliver her talk, and please be ready with your questions. And in the meantime, Dr. Nikhil, Dr. Anusha will be joining in
Uh,
shortly.
Dr.
Over to
Bhargav,
Dr.
yeah, I have joined in.
Oh,
If you
perfect.
could introduce Dr. Anna before the webinar.
Perfect. So, Dr. Nikhil, you can introduce Dr. Anna. We were waiting for you. Thank you.
Yeah, there was some technical glitch. Dr. Anna, if you could stop sharing your screen for a minute.
Oh, sure. Yeah.
Yeah. Is my screen visible in full screen? Yeah.
Yes.
First of all, thank you so much, Dr. Anna. I lost you in between due to some technical glitch. Thank you so much for joining in for this Innovations in Hematology webinar series. And thank you, Dr. Bhargav, for that introduction. From October 2023, since the first CAR-T has launched in India, we have done close to 20 CAR-T cell treatments at Fortis as commercially and many more as part of clinical trials. And as we do more and more CAR-T cell treatments, both for lymphoid malignancies as well as ALL, we tend to see unusual complications, more of HLH, many post-CAR-T cytopenias and infections. And I'm sure in the next few years, many more CAR T cell products would hit the market and it will be much more rampantly used. So this is a very appropriate time to discuss about managing post-CAR T complications. And we are privileged to have you with us, Dr. Anna. Dr. Anna Sureda needs no introduction in the hematology and oncology space. She is the head of hematology department in hematopoietic stem cell transplant at the prestigious Institute Català in Barcelona. She also heads the EBMT and is the current president of European Society of Blood and Bone Marrow Transplantation. Dr. Anna is an internationally respected clinical hematologist and a global leader in the hematopoietic stem cell transplant and cellular therapy space. She has made major academic and clinical contributions to the development and optimization of advanced cellular therapies, with particular emphasis on CAR T cell therapy. Her initial career work was focused on the treatment of Hodgkin's lymphoma and therapy for the patients, with more than 400 publications in international journals of repute. And today, we are happy to have her with us to share her extensive experience and expertise in early recognition, prevention, and management of post-CAR-T complications, which is very relevant for us considering that more and more centers in India and across the world are having access to this wonderful treatment. So I'll not take up much of time. Over to you, Dr. Anna. This is our team at Fortis Institute of Blood Disorders. Thanks to this team, we are able to do all the wonderful work that we do. Over to you, Dr. Anna. I'll stop sharing my screen.
So thank you very much, Dr. Kumar, for the really nice introduction, and of course for inviting me to participate in this meeting. Let's see if I can share the screen. Hopefully you can see it in full screen mode.
Yes, your screen is visible in full screen mode and you're audible.
Yes.
Perfect. Perfect. Thank you very much. So I think that the topic that I will try to discuss with you today is really very relevant, as you have mentioned, because we know that CAR T cell therapy is really very effective treatment for patients with relapsed refractory malignancies, basically for lymphomas and multiple myelomas and acute leukemia, but it's also associated to significant toxicity in the short, medium, and long-term follow-up. So it's really very important for us to better understand how we have to manage these complications, how we have to early diagnose them, and also some follow-up recommendations. So these are my conflicts of interest, and I would like to start my presentation with two or three clinical cases, basically to demonstrate how effective CAR Ts are and the impact that CAR Ts have had in our patients um, with high risk hematological malignancies. So this is a 40-year-old patient with a relapsed refractory diffuse large B-cell lymphoma that was treated with an autologous anti-CD19 CAR T cell, and you can see the excellent response on day plus 28 after CAR T cell infusion. So we know that for patients with multiple relapse or refractory diffuse large B-cell lymphoma, CAR T cells constitute curative treatment strategy. This is another example of the use of an anti-BCMA autologous CAR T cell construct in a patient with relapsed refractory multiple myeloma, also with an excellent response. The patient achieved an stringent CR on day plus 56 after CAR T cell infusion. But nevertheless, in spite of the fact that everybody is recognizing the efficacy of this treatment strategy, and also the fact that this treatment strategy has changed the treatment algorithms in some of the disease that we have been treating for many years, we also have to recognize that CAR T cells are associated with new toxicities that we need to learn, we need to understand why they are happening, we need to diagnose, and we need to treat in the most appropriate way. So here you have an example of potential toxicities associated to CAR T cell infusion. And let's go back to our 47-year-old gentleman with a relapsed refractory diffuse large B-cell lymphoma that presented on day plus eight after CAR T cell infusion, ICANS grade 4, and we will be discussing a little bit more in detail the neurological toxicity associated to CAR T cell infusion. And this is another complication that I will also be discussing later on in my presentation, which is hemophagocytosis, which is not a very frequent complication, but we need to be alert. And with that, it's really relevant and eventually life-threatening complication, which is also associated to a massive macrophage stimulation after the administration of CAR T. So this is a little bit the summary of the agenda for the presentation today. I will be discussing early toxicities, namely CRS, ICANS, macrophages associated hyperstimulation syndrome, infections. We have also to recognize that we have delayed and late toxicities, as you can see here in this slide. And it's really very important to take into consideration these mid and long-term toxicities, because in many cases, our patients being treated with CAR T cells go back to their original center. And this represents that we have to establish a multidisciplinary team to try to take care of the patient in a continued fashion and with a cross-talking, very close cross-talking information between the CAR T cell treating professionals and then the hematologist or the team that is going to receive the patient back home when the patient has been treated with CAR T. And then some conclusions and final messages. So here you have a little bit the timelines of the complications that I was talking about. Acute toxicities, namely tumor lysis syndrome, CRS, HLH, and MAS. And ICANS, we have delayed or mid follow-up toxicities, B-cell aplasia, hypogammaglobulinemia, GVHD, and delayed neurotoxicity syndromes. And then we have late toxicities, which might be related to immune-related toxicities and secondary malignancies. And as I have mentioned, some of them happen during the inpatient part of the process. Some of them can be happening when the patient has already been moved to the outpatient department. Some of them are mostly related to the infusion center, but some of them basically appear when the patient has gone back to the original center, and they represent really an important exercise of discussion between the infusion and the original center. So let's go to the first one, and let's start with the early toxicities. And here you have some physiology or physiopathology associated to the development of CRS, cytokine release syndrome, to try to understand it a little bit better. So we know the impact of the effector and inflammatory cytokines, the impact of the macrophage and monocyte system, which are the major source for IL-6 and IL-1, which are being considered the two major cytokines that are related to the development of CRS. And of course, at the end of the day, the inflammatory reaction by dendritic and endothelial cells. So CRS, as all of you know, is a supraphysiologic response following any immune therapy that basically results of the activation of endogenous or immune or infused T cells and or other immune effector cells. So the diagnosis is basically clinical. So we have to suspect CRS with high fever, hypotension, hypoxia, and organ dysfunction. But we have to take into consideration that CRS is not the only cause of fever in patients receiving CAR T. So when the patient spikes the first temperature, we not only have to rule out CRS, but we have to establish a very clear differential diagnosis that basically includes infectious episodes, which are also very frequent in patients and that receive CAR Ts due to the high level of immunosuppression. So CRS is the most frequent early adverse side effect associated to CAR T. We also know that CRS has not been equally reported with the different constructs that we have approved by both the FDA and the EMA. And in this slide, you can see some of the, let's say, some of the pivotal studies that gave the indication to TISA, to AXI, to brexucabtagene, and to lisocabtagene maraleucel in terms of CRS grading, grade 3 to 4, that ranges between 5%. You know that lysocell is the best tolerated construct, up to 23% in the case of TISAGEN. And we also have to take into consideration, looking at these percentages, that the incidence between the different products can also vary because they were measured with different scales. And this is something that we have been able to homogenize in the last few years. If we talk about anti-BCMA-directed CAR T-cell therapy, in the prior slide, we were talking about anti-CD19. Here we have some data regarding CRS and grade 3 or plus CRS with the two different constructs, ide-cel and cilta-cel, that we have available coming from the FDA and the EMA authorizations, as well as the median time to onset and the median duration. And again, here in these pivotal trials, CRS were not measured using the same degrees. So we have been able to recognize that there are some risk factors that are associated with CRS in basically the anti-CD19 directed CAR T-cell therapy. And we have factors that are related to the patient. So basically high disease burden, the underlying disease. It's more frequent to find CRS in patients with B-ALL in front of non-Hodgkin lymphoma, the presence of baseline thrombocytopenia, some indicators of endothelial activation, and the presence of active infection. And there are also some treatment-related prognostic factors. So lymphodepleting therapy, the type of co-stimulatory domain, so CD28, more than 1 for 1 BB, the high number of administered CAR T cells, and of course the high peak of CAR T cell expansion. So we can eventually, let's say, try to guess which are the patients that are going to develop CRS more than other patients' profile. As I mentioned before, we need to standardize CRS grading practices, and nowadays we are using the grading system established by ASTCT. And here you have the different grading from grade number 1, where there is no hypotension or hypoxia, the patient only is febrile, up to grade number 4, where hypotension needs to be managed by multiple vasopressors and hypoxia needs positive pressure. And of course, the moment to act, nowadays we know that it's grade 1 and grade 2. So if we are reacting with grade 3, we are basically too late. Which is the treatment strategy that we are using to manage CRS. This is another aspect that we have been learning over the last few years. So with grade 1, we may consider the treatment of tocilizumab, which is the first-line treatment strategy that we are using to treat CRS in our patients. Grade 2 needs to take into consideration the use of tocilizumab and corticosteroids, which constitute the second-line treatment strategy. And of course, in grade 4, we are planning to switch the type of corticosteroids from dexamethasone to methylprednisolone, and eventually to repeat more than 2 doses of tocilizumab, which is basically the number of doses that we are administering to our patients. So what to do with patients that fail to tocilizumab and corticosteroids? As usually, we don't have a clear consensus for that. And there are quite a few prospective clinical trials that are looking at the best treatment strategy. We can take into consideration siltuximab, which is an IL-6 antibody that has a higher affinity than tocilizumab for the IL-6 receptor. We can also take into consideration anakinra that crosses the blood-brain barrier, which is an antagonist of the IL-1 receptor. And then we can take into consideration other treatment strategies that have less clear evidence for this specific setting. So let's move to the macrophage activation syndrome, which, as I have mentioned before, it's not a very frequent side effect associated to CAR T cell administration, but needs to be taken into consideration, and the estimated rate is around 3.5. Unfortunately, it's a kind of gray area, and not only when we talk about patients being treated with CAR T, but also eventually when we think about macrophage activating syndrome in other specific fields. So we don't have uniform diagnostic criteria. There is no standard management protocol. And of course, ASTCT a few years ago also worked really very heavily in trying to establish a common nomenclature and a way to diagnose this specific, which is not very frequent, but has a high directed mortality side effect of the administration of CAR T. So here you have the definition. It's a pathological and biochemical hyperinflammatory syndrome that has the features of a hyperactivation of macrophage, that it's related to an immunoeffector cell therapy, and it's associated with progression or new onset of cytopenias, hyperferritinemia, coagulopathy with hypofibrinogenemia, and or transaminitis. And a key factor is that it's clinically independent from CRS. So it's really not very frequent to see CRS, let's say, coincident in time with this macrophage activating syndrome. So here you have, and this table has been taken from a paper published back in 2023, some common guidelines for identification. So the diagnosis is being made with this clinical manifestations and these laboratory abnormalities in the adequate setting, independent from CRS and ICANS. And here you have the most common manifestations and eventually other manifestations that can be present. So we have to take into consideration this elevated ferritin, then onset with resolving or resolved CRS or worsening inflammatory response after an initial improvement with CRS-directed therapy, eventually transaminitis, low fibrinogen levels, hemophagocytosis in bone marrow or other tissues, and cytopenias that are of new onset or that are refractory to treatment, along with other manifestations that need to be ruled out, but they are significantly less frequent. So, so it's first of all, it's really important to also to grade, to establish common grading approaches, as the one that you can see here, starting with grade 1, which basically represents a non-symptomatic or a mild symptomatic syndrome that basically requires observation and a clinical and diagnostic evaluation, and eventually intervention is not indicated, up to grade 4 that represents a life-threatening consequences with urgent intervention. And it's important to take into consideration this macrophage activation syndrome as an holistic consideration of a clinical picture that can eventually lead to the death of the patient. So here you can see, following the same paper that I have been mentioning before, some stepwise approach. So basically, it's important to introduce, as it happens in other situations in the treatment of our patients, that we should take into consideration one treatment after the other one. So to try to ascertain which has been the, let's say, the positive one and to which the patient has responded. So first-line treatment is basically based on the use of anakinra plus minus corticosteroid. If the patient is not responding correctly, second-line therapy can take into consideration the decrease of anakinra, corticosteroids if they have not been started, consider starting ruxolitinib that can be considered more strongly as third-line treatment strategy, and then consider alternative agents like low-dose etoposide for life-threatening toxicities. And of course, we have to evaluate during this treatment process other potential etiologies that may basically be the cause of this macrophage activating syndrome. So let's move to probably the third important early onset toxicity associated to CAR-Ts. Probably I would say that more frequent than macrophage activating syndrome, which are the immune effector cell associated neurotoxicity that we are calling all the time ICANS, which is basically a pathologic process that results in the activation or engagement of endogenous also or infused T cells following any immune therapy that is basically focused on the central nervous systems in terms of symptoms or signs. And you can see that it's really very rich in terms of clinical manifestations and in terms of symptoms. And one important thing to take into consideration is that all the symptoms that we can see in a patient that is developing ICANS can be common manifestations of other situations. So they are really not very specific. So again, which is the pathophysiology, it's less well understood than when we talk about CRS. There is a CAR-T cell direct mediated toxicity on CNS tissues that may have expression of the targeted antigen. There is an endothelial activation, and at the end, blood-brain barrier disruption, because CAR-T cell constructs have been able to be demonstrated in the cephalorachidid liquid. Again, ICANS have quite, let's say, a kind of well-designed process of appearance, taking into consideration day zero. Usually, they develop later on than CRS, when eventually CRS has already been resolved, or eventually CRS is not present, or as a continuation of a CRS that it's not evolving correctly. The presence of ICANS also depends on the type of underlying disease and the type of construct that we are using. And here you can have a similar table than the one that I have been presenting for CRS. And here we have to mention that axicabtagene and brexucabtagene are specifically notorious for the development of grade 3 or plus neurological toxicity. We also know that there are some risk factors that are associated with this immune effector cell-associated neurotoxicity syndrome. First of all, we have to take into consideration CRS, pre-existing neurological comorbidities, also high disease burden, high number of administered CAR T cells. Patients with acute lymphoblastic leukemia have more probabilities to develop ICANS, elevated LDH, and thrombocytopenia and endothelial activation, elevated ferritin, the co-stimulatory domain, the constructs that have as co-stimulatory domain CD28 are more prone to have ICANS as a clinical manifestation. And of course, also lymphodepleting therapy with fludarabine and cyclophosphamide. So there are several studies that indicate that a greater and earlier CAR T cell expansion and high grade or early onset of CRS predicts for severe ICANS. As we have seen with also with CRS, there is a grading that we have been able to learn over time, starting with grade 1, finishing with grade 4, that it's associated to the ICE score that you know that we are repeatedly doing in our patients that are being treated with CAR T every 8 or every 6 hours. Nurses play a fundamental role here because basically they are the ones that are in more frequent contact with the patient, and of course this ICE score is able to assess the level of consciousness. And the treatment strategies, of course, depends on the ICE score. What about diagnostic tests? It's important to do a brain MRI. That in a significant proportion of patients is normal. I mean, we have to do it because we have to rule other causes of neurological toxicity in this specific setting, but data coming from MSKCC that have a lot of experience with that indicate that in a significant proportion of patients, MRI is normal, but you have around 1/3 of the patients where there are some acute abnormalities that can be found. Additional diagnostic tests that we are doing. So we are studying the CSF, and we analyze the intracranial pressure. We do a biological analysis, a microbiology study. Sometimes these may not be feasible. It's usually abnormal, but the reality is that at first step, all these abnormalities are not very indicative, of course, of CAR T cell mediated toxicity, but if we determine CAR T cells, they are usually present in the CSF, and they do not seem to be related with the neurotoxicity severity. Another test that we are normally doing is EEG, that is usually abnormal in more than 80% of the patients, and more frequently, what we can see is a frontal or diffuse slow activity, and subclinical seizures may be detected. So basically, this is the workup that we are doing. And of course, it's really very important to rule out also infectious episodes or infectious complications associated to CAR T that can eventually mimic these ICANS, which is basically associated to the type of treatment. So management, of course, depends on the grading. And here you can see this paper that was published a few years ago following an EBMT, EHA-associated consensus. We need to understand when we have to get in touch with our neurologist from minute number 0, with our ICU consultants if the patient does not behave properly after the initial evaluation. We have to consider a transfer to ICU. Treatment of ICANS is basically based on corticosteroids, either dexamethasone, and followed by methylprednisolone if the patient is not responding correctly, and of course with anti-seizures drug, as you can see here in this slide. What about a third-line treatment strategy? As I have mentioned, as I have also mentioned before, um, there is no consensus for those patients that that don't respond correctly to steroids. And there are some data talking about the use of siltuximab, also about the use of anakinra, eventually the use of intrathecal chemotherapy that we have used a few number of cases in those patients that were not doing really well with the standard of care treatment strategies. Um, um, I think that when one of the discussions or one of the aspects that we have been discussing over the last years, since not only in the setting of prospective clinical trials, but basically when CAR-Ts were moved to clinical practice, is about the early use or prophylactic use, and we have some situations that are pros and cons. So we know that early use of TOSI and steroids can reduce the rate of severe CRS and end organ dysfunctions without affecting expansion, persistence, and response rate of CAR-T. There have been some studies indicating that the prophylactic use of TOSI or steroids in those patients that are at a high risk of developing CRS toxicity can be of benefit, but there are other studies that indicate really conflicting evidence, and the reality is that if you do a survey looking at the practices of different centers, there is not a common decision, and you will see that clinical practices with respect to the early use, eventually the prophylactic use, are quite variable between one center and the other one. And because this is one of the hot topics that we have to take into consideration when we treat patients with CAR-T, you can see here quite a few prospective clinical trials that are being done specifically in this setting to try to better understand which is the best time process to mitigate as much as possible CRS and ICANS. And the other important thing that I want to mention in this specific slide is that we have been able to improve our clinical practice. And when we look at grade 3 or plus CRS and ICANS in the real world evidence study that have been published, and this is kind of a rather older slide, but it basically represents what we are seeing nowadays. The reality is that with a better knowledge of the treatment strategy, a better knowledge on how to manage these patients, in clinical practice, grade 3 or plus CRS and grade 3 or plus ICANS are significantly lower to what was seen initially in the pivotal trials that gave the indication to all these constructs. Okay, so these are the short or the acute toxicities, but we have to take into consideration also the late toxicities and also late toxicities. So if we talk about early, mid, and eventually long-term toxicity, we have to talk about cytopenias, grade 3 or plus cytopenias that were already seen in patients included in prospective clinical trials, not only delayed cytopenias, but also late cytopenias lasting more than 3 months after CAR T-cell infusion. And this has been seen also in in many studies looking at real world data. And one important thing I think that I have on the slide regarding this aspect is that we have to take into consideration very seriously cytopenias, because the major cause of treatment-related mortality of patients being treated with CAR-Ts are not ICANS, are not CRS, are not macrophage activating syndrome, but are basically infections, which are associated in part to cytopenias. And we have been able during the last years to better understand different patients' profile, as you can see here on the left-hand side of the slide. So patients that have a quick recovery, patients that have an intermittent recovery, and patients that demonstrate a kind of a plastic phenotype, and also some prognostic factors that will eventually make us understand which are the patients that are that more frequently are going to develop prolonged cytopenias after CAR T-cell infusions, and which are the patients that are not going to have this specific side effect. And I'm sure that you know the CAR hematotox that was developed by Kay Rajewski and published several years ago in Blood, that basically is a score that it's based on bone marrow reserve and inflammation prior to CAR T, which is very easy to calculate. You can see here that it's taking into consideration the platelet count, absolute neutrophil count, hemoglobin, C-reactive protein, ferritin. So you can easily calculate your CAR hematotox score in your patients. And you have patients with a low risk profile where the median duration of severe neutropenia is significantly lower than for those patients with a high risk profile that is also associated with a higher percentage of patients with a plastic phenotype, severe bacterial infection rate, and severe infection rate. So this is something that we can use in our clinical practice, because this can eventually modify the way that we are using prophylaxis or eventually treatment in our patients. So this slide, I think that it's also of interest. This was a work being done by the EBMT and the EHA, basically to try to establish a common workout for patients that develop cytopenia after CAR T-cell infusion, considering eventually, depending on the situation of the patient, not only supportive measures like transfusion, the use of GCSF, the use of thrombopoietin analogs, but also the use of autologous or allogeneic cells in patients that have grade 3 or 4 cytopenias after CAR T-cell infusion. So, hypogammaglobulinemia. So it's also another, I would say, early, midterm, and long-term side effect of the use of CAR T. The incidence is less well described. It's better described in patients with relapsed refractory BALL that were treated with Tisacel, and it was very much related. I mean, of course, it's related to the B-cell aplasia, and of course, the disappearance of this hypogammaglobulinemia was associated in most of the cases with disease relapse. Over time, we have been able to better understand the use of IVIG replacement for these patients. We don't have a lot of let's say, prospective clinical trials that are looking at this specific topic, but nowadays we are using IVIG replacement in adults to keep the levels of IgG higher than 300, 400 milligrams, especially during the first 3 months. This might be controversial, but this is being used in some institutions. Depending on the adverse events and the infectious episodes that the patient can develop, routine IgG replacement should be carefully evaluated, and more intensive replacement strategies should be considered in pediatric patients and in patients with multiple myeloma that are being treated with anti-BCMA targeted CAR T cells. So, of course, associated to cytopenias, associated to hypogammaglobulinemias, we have to take into consideration infections in this specific setting. And I mean, I think that we don't have to go through all the different risk factors that patients being treated with CAR T have to develop significant infections that, as I have mentioned before, maybe this slide, it's a little bit too small in terms of font. They represent the major cause of treatment-related mortality. And what it's important to take into consideration is that infections do not only occur during the early and the midterm episodes, but we have a significant proportion of patients that develop late infections. So more than 3 months after CAR T-cell infusion. And as I have mentioned before, this is really important because many of these patients are already in the outpatient department, and many of these patients are already or have already gone back to their original center. Infections have also their pattern of appearance, and here you can see that although bacterial infections can be seen in the phase 1, phase 2, and phase 3, which is the late phase, then we have viral infections and fungal infections that are much more frequent during the phase 1 with acute toxicities and phase 2 delayed toxicities. And these can be better seen here. So in the first months, if we think about infections, we have to think, first of all, about bacteria, viral, and finally, fungal infections. Over time, viral infections probably take the lead in front of bacterial infections, and the probability to develop fungal infections decreases over time. And this is what I was basically mentioning to you before. This is a very interesting study that was published in Nature Medicine in 2024 that was looking at non-relapse mortality of patients with lymphoma and multiple myeloma being treated with CAR T cells with the different constructs that were available. So we have always to think that infection represents the most important cause of non-relapse mortality in front of ICANS and in front of CRS. And this study represented a systematic review and a meta-analysis of patients included not only in pivotal prospective clinical trials, but also in real life analysis. So we have been able to develop some guidelines and local practices with respective to anti-infective prophylaxis. So we are using antibacterial prophylaxis in high-risk patients. We are also using antifungal prophylaxis. We are using pneumocystis carini prophylaxis during at least 12 months until CD4 positive cells are higher than 200. Antiviral prophylaxis with a cyclovir also during 12 months until CD4 are higher than 200 cells per microliter. So there are some general guidelines, and of course there are some local guidelines that need to be taken into consideration with specific characteristics on specific places. We have also learned on how to vaccinate our patients, and generally take into consideration that inactivated vaccines have to be given from after the first 3 to 6 months after CAR T-cell infusion, attenuated vaccines in patients after the year or the first 2 years, after confirming that the patient is not under any immunosuppressive treatment and has recovered from the B-cell aplasia. But it's important to establish a vaccination protocol in these patients in the same way that we have established it for stem cell transplantation recipients. And sometimes we are copying and pasting our knowledge from the allotransplant setting to the CAR T-cell transplant setting. Other, let's say, relevant, although less frequent side effects. We have to take into consideration secondary malignancies that have been demonstrated and that have been presented in patients being treated with CAR Ts. And here you have some data coming from the Hutchinson experience. So basically, myeloid malignancies and the rate of secondary malignancies and treatment-related MDS is within the range of expected risk in the non-Hodgkin lymphoma population and in the post-autologous stem cell transplantation population. We also have to take into consideration the risk of T-cell neoplasm and related to the viral vector integration, which was an emerging concern that was brought by the FDA several years ago. The reality is that this has not been able to clearly demonstrate in additional studies that were developed later on. But of course, this is something that we need to take into consideration. And we also have to take into consideration other less frequent late adverse events like immune-related adverse events. And um, we have to take into consideration some neurological events and also psychiatric events that have been seen in some patients that have been alive for many months after CAR T-cell infusions. Only one word, I think I am running a little bit out of time here, is that we have to take into consideration delayed neurological complications like delayed Parkinsonism, cranial nerve palsy, and neuropathies in patients that are being treated with anti-BCMA CAR T-cell constructs. And this has been clearly demonstrated with basically one of the two anti-BCMA constructs, basically cilta-cel more than ide-cel. So something to be taken into consideration specifically in these patients. And here you have a list of non-ICANS neurological complications, and I would really recommend you to read this Lancet Oncology 2025 paper, that it's an harmonization guidelines paper, also coming from the EBMT, looking at CAR T-cell therapy associated neurological toxicities. The GVHD might be long-term side effect associated to CAR T. There are some reports looking at this side effect specifically, but we have to say that the exacerbation of GVHD is not markedly increased after CAR T-cell therapy, so something to take into consideration, but it's not very frequent. Apologize because this slide is partially in Spanish, but wants basically to reflect other potential non-frequent late adverse events, basically cardiotoxicity and hemorrhagic and thromboembolic side effects, which can be better seen in this paper that was published in 2021. So important to take into consideration cardiovascular adverse events that have been reported also in this meta-analysis of CAR T non-relapse mortality related causes. So another, and I am finishing here, another, I think that important thing to be taken into consideration, as I have mentioned several times, is the importance to establish, let's say, a well-developed protocol to transition patients between the infusion center to the original center, and the importance of having an adequate crosstalk between both centers to transition the treatment strategies from one center to the other one, trying to keep both groups of professionals in an adequate relationship. And here you have a little bit how we are doing monitoring of patients in the first month after infusion, from day plus 30 to day 100 after infusion. And this is the late effect monitoring from day 100 to 1 year, from 1 to 2 years, and from 3 to 15 years annually. And then, of course, you can do a little bit of telemedicine here and follow your patients with virtual monitoring. And basically, that's the end of the presentation. So we have to recognize that CAR T-cell therapy has an acceptable short and long-term safety profile, but we really need to understand which are the acute toxicities, which are the late toxicities, to early diagnose them, to try to use prophylaxis, and to try to treat them as quickly as possible. And of course, this is being made out because of a multidisciplinary team that is basically represented here in this slide, having the hematologist in the infusion center and the referral center in, let's say, in the center of all this process. And the reality is that the long-term outcome of our patients being treated with CAR T is highly dependent on this close communication and this establishment of consensus protocols, which are essential to monitor our early, midterm and long-term toxicities. Okay, so thank you very much for your attention, and I'm going to stop sharing and happy to take some questions.
Okay, thank you very much, Dr. Anna, for the crisp and deeply engaging talk and for generously sharing your experience with us. With your permission, can we move on to the question and answer session? Am I audible, Nikhil?
Yeah, you're audible.
Okay. Dr. Anna, I'll start off with the questions, and then if there are some questions from the audience, we'll put that across also to you. Moving on, first, you clearly explained the pros and cons of prophylactic versus preemptive versus early use of tocilizumab in a CRS event. What is your practice, madam? And do you ever decide it based on the disease burden at the start of the infusion, whether you're going to go preemptive, whether you're going to go early prophylactic?
So we are not doing preemptive therapy in any of our patients. As I have mentioned, the literature is a little bit still conflicting, and I think that we are waiting for the results of prospective clinical trials that will be able to guide us a little bit more. We are not using preemptive. We are using early treatment for those patients with high risk disease, taking into consideration the prognostic factors that I basically outlined in one of the first slides. So basically, treatment-related factors and basically disease-related factors or patient-related factors. So in those patients, we use early treatment with tocilizumab, but we are not using preemptive therapy in these patients. And I have to say that this is not an homogeneous practice across the board. I wanted to mention that we are conducting a survey in looking at US centers and European centers spread out in different European countries. We are preparing, hopefully, an abstract to be sent to the next EHA meeting. And let's say the preliminary results of this survey is that the clinical practice is by far non-homogeneous at all, and there are really different practices across different centers. So I think that um, one of the pending topics in which we need to work in the future is to have more prospective clinical trials looking at the pros and cons of this preemptive use, early use, and of course look at our clinical daily practice to be a little bit homogeneous. At the end, when we started to see the results of pivotal studies with respect to CAR T cells, it was very difficult to compare upfront the incidence of CRS, the incidence of ICANS, because the scales that were used were completely different. Nowadays, we have an homogeneous way to identify our patients, to grade our patients, but we are still having quite a lot of differences in terms of how we are using tocilizumab, how we are using corticosteroids. So this is one of our pending topics.
Okay. I think even in India, the practice is very heterogeneous, and we tend to play it safe in very high burden disease. We manage, balance out the infection risk. And in our center, particularly, we tend to use prophylactic with a very high disease burden. And so far, those cases have been going on smoothly. But I understand where you're coming from when you say the practice is very heterogeneous. Do you just use IL-6 to guide this? Of course, clinical parameters always cover for infections, but how often do you check IL-6 and what sort of a trajectory do you use to guide your tocilizumab use after the onset of any symptoms?
So we are monitoring IL-6 and IL-1 regularly in our patients being treated with CAR T. Our treatment decision is mostly based in clinical symptoms of the patients more than in lab values. So we are following the patient with lab values, but we are, let's say, basically the treatment decisions are based on clinical signs and symptoms of the patients.
Sure, that makes sense. Do you have any take on the early use of growth factors in this situation? Is there any thought towards it may precipitate an HLH-like syndrome, or it may impair the ongoing effectiveness of the CAR T itself?
Mm.
Any thoughts on that?
So we try not to use them. We try not to use GCSF very shortly after CAR T-cell infusion, basically because of all the concerns that you have mentioned. But in some specific cases, if the patient has a very severe infection and the patient is really severely cytopenic, we are using the hematoscore, the hematotoxic score in all our patients. I don't know if this is something that you are calculating in your patient a little bit to better understand which is going to be the risk in terms of cytopenia after CAR Ts in our patients. So in a selected group of patients, we use GCSF shortly after CAR T cell infusion, but we are not doing it regularly in all our patients, only in those patients with high risk score.
Sure. Um, with respect to HLH, I think the Indian commercially available Indian CAR-T that we have has a slightly higher incidence. In the series that we are coming to with the data in Palma this year, we have about 30% of our patients who have an HLH-like syndrome. Interestingly, in your slides, I noted, is there any role of a wait and watch approach in HLS with respect to grading? Or it's because my understanding was you catch it early and you treat it and you don't wait for it to progress. But when you grade it, and is there any window at all for a wait and watch approach in this?
So I have, first of all, I have to mention that sometimes I think that the percentage or the incidence might be higher than what it's being presented, because it's really very difficult. Well, sometimes it's difficult to diagnose, and you have to be really experienced to do an early diagnose. I think that, of course, if you do an early diagnose and the patient is stable, you might want to observe, but the reality is that as soon as you diagnosed it, the better to start treatment, because if not, because if not, the evolution might be really fatal. So as when it's being diagnosed, I think that the best way is to eventually start treatment. Of course, if you are using a very fine-tune early diagnose, you can eventually, in the meantime, while you are trying to rule out other potential causes or other potential etiologies, you may want to wait.
Exactly. Right. In the same context, do you use any particular trajectory of ferritin to quickly put your differentials in the order of HLH versus this? Of course, clinical examination and findings are supreme in this, but beyond that, using lab parameters to support this, how do you go about this?
We are very much relying on ferritin. And apart from the clinical parameters, we are using ferritin to start as quickly as possible treatment for HLH.
Okay. Um, with respect to treatment, in our setting, sometimes there's a slight bit of a delay in arranging anakinra, not always. So we do start off with steroids while we are arranging it. But given an option and in settings where both are immediately available, what would your go-to choice be? Would you want to avoid steroids? Because the flowchart as it says anakinra plus minus steroids. So how do you go about it, ma'am?
So we try to use anakinra. I think that all of us steroids are really very effective, but everybody knows that steroids are really super immunosuppressive, and we know that those patients that have been treated with steroids for whatever reason, they are more prone to have infectious episodes later on. So we try to avoid them. We are using anakinra as first-line treatment strategy. If the patient is not responding well, then we start with corticosteroids, and in some cases, we have been using also etoposide in the same way that we are using it for other macrophage activation syndrome outside CAR T-cell treatment strategy.
With respect to overlap in cytopenia etiologies, how late in post CAR T infusion would you still suspect an HLH, or would when it starts becoming much lower down and you just think this is probably going to be just a post CAR T cytopenia? of course, fever and fibrinogen aside.
Exactly. Well, we try to make the diagnosis, I mean, with all the lab and the clinical characteristics. And of course, if the cytopenias are more delayed, we think that probably these cytopenias are more related to CAR T cell infusion more than HLH.
Okay. So I think you already answered about your questions about the prophylactic IVIG use. Beyond 3 months, it's just based on monitoring and no prophylactic use. Is that correct?
So well, first of all, IVIG are very expensive. Of course, that's nothing related to clinical practice, but they are really very expensive. And at least in Spain, we have suffered from some shortage of IVIG in certain periods of time. Um, we don't use universally prophylactic IVIG in all our patients. We are using it more for our patients with multiple myeloma. We are not pediatric institution, so I don't have experience with the use of CAR T cells in pediatrics or eventually young adolescents. Um, and for patients with B-cell lymphomas that are being treated with CAR T, the use of IVIG depends not only on the levels, but the development of serious infectious episodes. So we don't start using IVIG if the patient is non-symptomatic, even if the levels of IgG are below the standards.
Sure, understood that. I think you clearly mentioned that we are extrapolating the vaccination schedules from our
Yeah.
transplant experience to CAR-T. I know that there's no right answer to this, but what are you doing in your practice, ma'am? We do have a abbreviated post-CAR-T vaccination schedule that our infectious disease team advises. What are
Mm.
you doing in your practice? We would like to know,
So as I have mentioned, I mean, initially we extrapolated a little bit the vaccination program from the allotransplant recipients. We work very coordinately with infectious disease and also with prevention medicine in our institution. We are using um, uh, death viral vaccination from 6 months onward. And then in long-term in long-term survivors, we continue with the vaccination program. And we we are still doing a little bit a similar practice, let's put it this way, than what we are doing with our allogeneic stem cell transplantation recipients.
I think, Dr. Anna, before we move on, we have a lot of questions in the chat box. So I'll try and take them one by one. Dr. Anushri wants to know precursor B-ALL refractory disease. Post CAR T patient achieved MRD negativity. Unfortunately, relapsed 3 months post CAR T. Now the patient has a donor and is planned for a transplant. So, any role of a second CAR T to get him into remission prior to transplant?
So, let's say, first of all, I am not a pediatrician, so probably I am not the best one to answer this question. But let's say, using a little bit my adult, let's say my adult experience, I think that this patient should be considered a candidate for an allogeneic stem cell transplant. And let's say, listening to pediatric audiences, um, as opposed to what is happening in the adult setting. In the pediatric setting, CAR Ts in many occasions are being used as a bridge to transplant. So I would eventually take into consideration this proposal, try to bring the patient in an MRD negative situation with another CAR T, and then consolidate the result with an allogeneic stem cell transplantation.
On that same note, Dr. Anna, in adult patients, ALL patients who receive a CAR T, do you consolidate all of them with an allogenic transplant?
Not, no, not all of them. First of all, because some of them have already failed an allogeneic stem cell transplantation when they receive CAR T. And of course,
Yes.
the tolerance to treatment of patients, of adult patients, is not the same one as pediatric patients. We follow very closely minimal residual disease after CAR T. And also, there are some patients, depending on the high risk relapse profile, we can eventually consolidate them with an allogeneic stem cell transplant. But in most of the cases, the answer would say no, we are not consolidating this patient with an allo transplant.
And on that note, in lymphoma patients, do you have any protocol if patients have a loss of B cell aplasia? Is there any group of patients whom you would consider for an allogeneic transplant in your lymphoma cohort?
So I think that there is no information out there that can clearly inform us which is the best way to do it. From in the lymphoma setting, ideally, and I'm saying ideally because we don't have in place ctDNA to follow these patients. I would like to follow these patients with PET-CT and ctDNA. There is no indication outside prospective clinical trials to consolidate or to maintain or to give maintenance therapy to patients with lymphoma that are in metabolic complete remission after CAR-T. There are prospective clinical trials that are considering using biospecifics or other drugs in patients that don't achieve a partial remission, that don't achieve a metabolic complete remission. 1 month after CAR T cell infusion, which is basically the time frame where we are analyzing the results of CAR T. So we closely monitor outside prospective clinical trials, we closely monitor our patients, and if the patient loses the concept of metabolic complete remission, then we treat these patients. The use of allotransplant, yes or no, it's quite controversial because we know from data from long-term follow-up of patients being treated with biospecifics, having relapse after CAR-T, those patients that achieve a metabolic complete remission, they have a very nice duration of complete remission. And allotransplant, and of course I have been doing allotransplant for many years, it's still associated with non-relapse mortality. So if the patient achieves a complete remission, probably we would not recommend the consolidation with an allogeneic stem cell transplantation. If the patient does not achieve a complete remission, we might recommend consolidation with an allotransplant as a curative treatment approach.
Great. I think in our setting, probably with limited finances, very often we try and bridge them to a transplant because many
Yeah.
of them are not able to continue bispecifics for long. And on that same note, thankfully, we have Dr. Srinidhi in our team, who's a molecular hematologist, and we have an in-house ctDNA monitoring. We are trying to standardize it in a post-CAR-T setting to see whether we can pick up relapses earlier than what we would with a PET-CT monitoring. So any take on that? And Dr. Srinidhi, if you are around, you can also pitch in.
Sorry, go ahead.
No, please go ahead. Please go ahead.
As I have said before, we don't have in place an standardized MRD monitoring with ctDNA using all these kind of well-established platforms. Ideally, for our lymphoma patients, I would like to use the combination of PET-CT with ctDNA to evaluate disease response after CAR-T or eventually disease progression or relapse after CAR-T. I think that we need more data on that. And the reality is that most of the prospective clinical trials that are ongoing or that have already finished have incorporated as third line objectives or exploratory objectives the analysis of minimal residual disease that has demonstrated to be a very potent prognostic factor. Unfortunately, not able to use it in clinical practice and very difficult to extrapolate it, let's say, in a multi-center clinical practice setting.
So I'll just add that in a very short experience of, maybe around 12 to 15 cases, if I'm not mistaken, Dr. Anusha.
Yeah, that's right. I think we have 16 now, but 12 at least with recent.
Yeah, so I think we've done a pre-CAR T, we've done day 28, and then we've done it every 3 months along with the PET scan. And we seem to have a correlation. And Dr. Anusha can actually throw more light on the clinical aspect, the clinical utility of the ctDNA. My job was to standardize that assay and give them a robust assay, which is error corrected NGS, and then just trying to validate it more and more. But the clinical utility, these guys are the bosses for that, so they have to tell you that whether if it's clinically making any sense to them or not. She has some initial data on that. Probably she's presenting it in Spain as well. So can you share that?
Yeah, I think there have been one or two molecular discordances. If I'm not wrong, two patients did have a early molecular discordance with the PET imaging. Another thing we are trying to correlate, I think there's a question in the chat box as well from Dr. Gopinath, if we can get a correlation between the loss of B cell aplasia and the ctDNA and then the PET scan as well. I know these are two separate questions, B cell aplasia by itself and then ctDNA and then the correlation with PET scan. But yes, most of the patients do have a molecular and clinical concordance, which is more reassuring that going forward, we don't have to regularly monitor them with a PET scan as such. But yes, one or two early molecular discordances which settle down by day 60, day 90 going forward. On that note, ma'am, what is your take on B cell aplasia loss? I know it's different for different CAR-T constructs, but how are you approaching it at present?
So, as I have said, I think that the clinical meaning of a B cell aplasia loss depends on the underlying disease. I don't have a lot of experience with BALL, basically because the only construct that is approved and reimbursed in Spain is Tisacel, which is focused in children and early and young adolescents or young adults. So our experience is really very limited. We are following in all our lymphoma patients B cell aplasia. If the patient is in complete remission, following the standard strategies that we are using to consider a patient with lymphoma in complete remission, we are not doing anything with this B cell aplasia. I would say that as I mentioned before, in the ALL setting, the situation is different.
And
Okay,
Dr.
that
Anna,
makes
moving on with the questions in the chat box, Dr. Amrita has a question. Very often, ICANS can mimic meningitis. Even with an MRI picture, it may be very tricky to decipher. So, if a CSF analysis is not feasible either due to cytopenias or agitation, would you treat them with empirical antibiotics? And there's another question. Is there any role of prophylactic antiepileptics in patients who are at high risk of ICANS?
Okay, so let's start for the second one. We are not using prophylactic anti-epileptic drugs in patients which are at high risk of ICANS. We establish the treatment as soon as the patient has the minimal symptom of ICANS, and we are very vigilant on that. And answering the first question, we always have the massive support of our neurologist consultants that are really very experienced with CAR T-cell treating patients, and we have associated antibiotics or eventually antiviral treatments if there is a suspicion of meningitis and for whatever reason, and this is one thing that I mentioned super briefly in my slides, we cannot get CSF a fluid to do the adequate analysis and the adequate differential diagnosis.
Absolutely. I think it's a challenge treating these patients, and getting
Yeah.
a sample may not be always possible. And on that note, in your slides, you had mentioned in severe ICANS the role of intrathecal methotrexate and even other
Yeah.
agents like cyclophosphamide. So, how often have you had to use these agents in practice? Like, do you do it for grade
Oh,
3 ICANS, which is very severe, or what is your threshold for using that?
so so starting with the second question, let's say ongoing grade 3 that it's not responding adequately to treatment, and very infrequently we have used basically cyclophosphamide. in those patients with severe and non-responsive ICANS, but very infrequently. If I remember, 2 to 3 patients, not more than that.
Dr. Gopinathan has a question on prophylactic IVIG. His question is, how early should IVIG be initiated? And if patients have a very low IgG levels at baseline, should it be given earlier?
So I have answered this question a little bit with my prior comment. It depends a little bit on the type of patient that we are facing and the type of construct that we have administered. With lymphomas, we are a little bit looser in terms of not using IVIG if the patient has not had any severe infectious episode. With multiple myeloma, we are much more concerned, and we are using IVIG even if there is no infectious episode.
And Dr. Anna, in our practice, we see a lot of CMV reactivation. And Dr. Neha, who's our infection disease specialist, very often we see CMV reactivation in the setting of a CAR T. So a couple of questions on that. Any role of letermovir prophylaxis in this setting? And if patient has already had a CMV reactivation, has been treated with ganciclovir or Valgan, would you put them on a letermovir prophylaxis post treatment?
So we are not using letermovir prophylaxis in our patients. We are not seeing so much or so many CMV reactivations. And if the patient has a CMV episode that has already been treated, we would be considering letermovir. After having said that, letermovir is not being reimbursed in Spain because of this specific indication, and we would have serious problems with our pharmacy if we try to establish it. Probably we would be unsuccessful. But anyway, going back to clinics, which is the most important thing, CMV reactivation is not it's not a major issue in our patients.
Right. Dr. Neha, any comments on that if you're around, your experience with CMV in these patients?
Yeah, hi everyone. Hi, Dr. Anna. So we have seen CMV, couple of them, because of course we come from a quite seroprevalent region where the CMV seroprevalence is pretty high. And we have come across the CMV viremia, which ranges from a low level most commonly because of the fact that the patients have already been treated heavily on the terms of the first line and then second line and then landing, especially when I talk about the BCMA CAR-T preparations. So the idea is that those population, if we can have a little movie, but as ma'am said that no much incidents in their practices, though one of the big papers from the Nature reviews, which they have seen, they have found out close to 12 to 15% of the CMV incidents. But honestly speaking, no much of guidelines to throw the light on the letermovir usage and practice, and I think it will be very customized. But yes,
Yeah.
we have seen CMV viremia close to, if we talk about, we have done so far those 30 plus patients. So we have found out close to 8 to 9 patients having a low level CMV viremia.
That's almost
Exactly.
1/3 of the cohort.
Yeah, right.
I have to say one thing, that the Spanish population, almost all of us, we are CMV positive. So as opposed to, for instance, when I was working in UK, in UK there was a significant proportion of patients. Now I'm talking about allogeneic transplant recipients, not about CAR-T. Because at that time CAR-T were not existing in our clinical practice. But in Spain, I would say that more than 90% of the population is CMV positive. But I have to say that in our CAR-T cell practice, we have not seen so many CMV reactivation. So it's not such a big clinical problem. But as you said, I think that this needs to be customized. So I think that we are working in a kind of harmonization clinical guidelines on how to monitor, how to use preemptive therapy, prophylactic therapy, and vaccination in our patients. After having said that, I think that these general guidelines need to be customized, as you have said, for specific settings, because the infectious disease profile overall not only the bacterial, but also the viral and the fungal infectious disease profile is very different from one place to the other one.
A
Right.
couple of
Right, good point.
questions on post-CAR T cytopenias. How liberally would you use growth factors or eltrombopag in this setting when patient has a prolonged cytopenia post-CAR T?
So, so only one thing. I will have to leave in 5 minutes because I have another meeting.
Okay.
I'm really sorry about that because I mean the discussion is super interesting. But anyway, so if the patient has profound cytopenias, we use quite liberally GCSF and L-Thrombopag. We do bone marrow biopsies and bone marrow aspirates because we want to rule out cheap abnormalities, potential myelodysplastic syndromes that are eventually found in these specific situations and that can eventually be the responsible for these cytopenias. And we give a try. I would recommend you because this paper is really interesting. It's a blood paper. I think it's from 2024, which is the EBMT EHA guidelines. Um, regarding how to study in an, let's say, in an organized way, cytopenias after transplant, the impacts of CAR hematotox, and then the treatment strategies. But of course, if with analogs and with GCSF, the patient does not respond and there is no evidence of myelodysplastic or chip abnormalities. Eventually, there have been some reports on the use of autologous stem cells if the patient has um, if the patient has frozen peripheral blood stem cells, which is not frequent, or eventually an allogeneic stem cell transplantation as a rescue strategy for these severe and prolonged cytopenias. You always have to balance pros and cons of the different. Of course, you don't want anybody to die from infections, but let's say an allogeneic stem cell transplant in somebody that has received a CAR T, it's also a major treatment strategy, so it needs to be clearly balanced.
Absolutely. Can we take one last question, Dr. Anna?
Yes.
Yeah. So before we wind up, our last question from Dr. Roy. It's actually a case that he wants to discuss. It's a 36-year-old female, PMBCL, relapse refractory, post CAR T day 30 in remission, and day 60, unfortunately, there was a progression with mediastinal mass. Now the patient has been treated with 3 doses of tislelizumab, and a repeat PET shows resolution of the lesions except for a 3 into 4 centimeter dual file lesion. He wants to know what's the best approach. Radiate and go for an allo, or should we go for a salvage or allo? Patient is not affordable for any more bispecifics.
Okay. So, I mean, it's always difficult to make a firm conclusion on these patients. Um, I mean, without having all the specific details, but personally, what I would try is to radiate the lesion that it's double five and then consolidate the patient with an allogeneic stem cell transplant. With this, you run the risk that you have a disease escape during the radiation strategy, and then that the patient is not candidate for an allo, and then you have to go to salvage therapy. But if you go to salvage therapy, we cannot forget that the patient is only 2 months after CAR T. Salvage therapy can have quite a lot of hematological and extra hematological toxicity, and then the patient will lose the performance status to be a good candidate for an allo transplant. So probably balancing the pros and cons, I would suggest radiation of this area and proceed as quickly as possible to an allo transplant.
I think that with that, we come to the end of the question and answer session. Thank you so much, Dr. Anna, for sparing your valuable time and such a wonderful lecture where you took us through the entire complications and a lot of practical takeaways from that for hematologists and oncologists alike. Thank you so much for joining in, and we hope to collaborate with you in future. Dr.
Thank you
Bhargav,
very much.
Anusha, and each and everyone who joined in and enrich today's session. It was wonderful having you all. Thank you so much.
Thank you very much, and see you in Palma de Mallorca for those of you that are going there. Thank you.
Looking forward to meeting you there.
Thank you. Bye.
Thank you, Dr. Rena. Bye-bye.
Thank you.
Bye.
Thank you, Dr. Nikhil. Thank you.